Can I have everyone sound off? No? Okay.
Sure.
No, I'm just kidding. All right, guys. You're gonna have to give me a little bit of grace. I'm only using my laptop and my trackpad, and I'm trying to do some things with a small laptop screen instead of my big, huge monitor. So let's see how this works.
Hey, Andrew, will you unpin Vince?
Dr. Kim, are you making TikToks in the background?
I thought I had, but yeah, sure.
I'm making what?
Are you making TikToks with that fancy camera?
What's a TikTok?
Never mind.
Who's talking? Okay, so I had like a million windows open, so I'm gonna do two things. I'm gonna do one of our rapid shorts, so that'll be about 15 minutes, and then we'll go into some migraine stuff. I'm just pulling up a bunch of EKGs and goodies. So for those of you who have not got to participate in our rapid shorts yet, just a reminder what it is. We'll be doing about 15-minute sessions of high yield things, of things that we just need to see again and again and again in a longitudinal format. One of those things being an EKG. So this is different than the other EKG series that I've been doing, because we're not gonna go into a system. We're gonna focus on like that one or two things that we're really trying to learn from it. Last week we did the quality, assessing the quality of a chest x-ray. And this week we'll be doing EKGs, and we're gonna start with a case. I'm just, oh shoot, I got like a lot of windows. Okay, I'm gonna delete, close these, and open a bunch of cases. And I'll be sharing my screen, so get ready to have some fun. All right, I think we're on the right one now. So while I'm sharing screen and doing things on a whiteboard, it is a little bit difficult for me to see the chat box just because of the screen real estate. And so I would ask that you guys chime in on the microphone. So Andrew, go ahead and start the poll question, because it's gonna have the actual text of the case. So you all should see a poll right now. It has one sentence. It's a 40-year-old African-American male, diabetes, cholesterol. He's got some atypical chest pain, and there's the EKG. So multiple choice question. So take a look at the EKG. And then if you want me to zoom in on certain parts, feel free to shout out where you want me to zoom in. I think a lot of you, I see a lot of faces squinting at me. I like that. I'm gonna zoom in to the precordials, because I think that's where you're squinting. And you're trying to decide if something's going on. So what I'll do is I'll zoom in even more to one of the precordials, and I'll slowly move on to the next precordial. Look at these faces, I love it. Okay, the next precordial. Oh my goodness. Okay. So there's that, and then there's a view of the limb leads. They're usually pretty important too. So Andrew, does it say how many responses you have?
It's like about half.
So maybe like 30 more seconds so people can choose. There's a view again. Let me know if anyone wants me to zoom in somewhere else again.
All right, we got a few more there, so we probably just stop it here.
Okay, and then go ahead and publish the results so we can all see it.
Okay. If my answer is right, I answered it. If my answer is wrong, Molly answered it.
So the winner that most people think this is a STEMI, and I agree with you, it's pretty concerning, especially with the history, right? He's got some risk factor. He has some chest pain, comes to the ER, you see those ST elevation. This is actually benign, completely benign. And this sort of thing happens all the time. And it's much more common than you think, especially if you're like just the ER doctor. Like we don't see a lot of these actually because they don't admit these kind of people. Well, this person maybe, who knows, whatever their heart score was. So we'll go into it. Like what the heck makes this benign? Because it looks like, you know, people saw some diffuse ST changes. So they're thinking like pericarditis. A lot of people thought it was STEMI. Some people thought it was benign. So there's something here, right? And so let me stop share that and then go to the whiteboard real quick. So what we're going to talk about for today's rapid short is this term that we see, benign early repole. We're going to see it a lot, and it's actually pretty common. In fact, let's go ahead and define it. So it's called a couple of different things. You'll see different names. J-point elevation, high takeoff, and typically you see these in anyone who's less than 50. So if they're over 50, I mean, there's a bunch of other data, but if they're over 50, this doesn't apply. So just keep that in mind, especially if they're elderly. It never applies to elderly. Here's the incidence that I found of benign early repole. In the emergency room, 10 to 15%. And just like we pointed out, it has some widespread ST elevations. So oftentimes it gets confused with MI, pericarditis, and anything else that can be causing or making you concerned for it. So I saw someone selected Brugada because they're worried about ST elevations, but not really being that significant. So what the heck do we look for? What are the actual like little things that you look for? I think no one actually went over this with me in my training, so I thought it'd be good to do it with you guys. And anyone can feel free to chime in because I know there's some EKG fanatics out there. So this one's pretty, first criteria is pretty self-explanatory. You have ST elevations, yeah, especially in the precordials. But here's the thing, it's gonna be concave. And so let me see if I can draw it. I'll have a picture to show you later too. So what that just means is, see that smiley face? It's concave up, that means good, people are happy. So that ST elevation, when it comes up, it's gonna be, oh, that's horrible. Oh, that's bad. But you guys get the point, the ST. Oh, gosh.
Will Parkinson White.
Yeah, there's a delta wave there. But the concavity is generally concave up. We're gonna look at a bunch of other examples, so don't get too caught up on my horrible drawing. Number two is there's a little notch or a slurring of the J-point elevation. So it's not like a very obvious tombstoning ST elevation. It's either a notch or a slurring of the J-point. The other thing is how the T waves look. The T waves should be pointing in the same direction as the ST elevation, because a lot of times with real true ACS, we're worried about the T wave inversion. This one, the T waves are always in the same direction, and they're kind of not symmetrical. So that's the other thing that you'll find all the time. So you'll see a smiley face, and then you'll see either symmetrical or asymmetrical T waves. And then on all the examples we're going to look at right now, you'll also note that none of these are that like tremendously elevated. So just little elevations is typically what you're going to find. They have all these other criteria like 25% less than the highest wave and T wave, blah, blah, blah. I say, you know, forget that, just a little elevation. So if it's a big elevation, go ahead and increase your index of suspicion. Here's kind of the little criteria. All right, here's the big guy. Boom. There's never, ever, ever any reciprocal changes with benign early repole, otherwise it's not benign. So reciprocal changes are basically anatomically on the other part of the heart. So if you have an elevation, just logically by how vectors work in the body with the electrical stimulus, if it's pointing towards the point of insult, that means the opposite side should be having a deflection downward. So ST depression. And then the last one to really look at, and this kind of makes sense, is just stability over time. So if you get some serial EKGs and the clinical picture is changing, the ST segments are not changing, the T waves and everything else still looks the same, it's probably benign early repole. But let's say you start getting progressively worsening T waves or flip T waves 30 minutes later, then you can't just chalk it up to benign early repole. So with that said, I mean, you could take a screenshot. I mean, I'll leave it up, but we're going to look at some EKGs. So you can take a screenshot or try to memorize it. So again, concave ST elevation, notching, they even call it like a fish hook, or slurring of the J point. The T wave should be asymmetric and pointing in the same direction, and just little ST elevations, which is why it's always tricky. And then no reciprocal changes and stability over time. So with that said, I'm going to pull up we're going to go through couple cases here. And we're going to decide together if we're looking at benign early repole or something else. So this is case 276. Let me pull that up. All right, guys. So let's start applying our criteria. So this case, I'll actually read it to you. 32-year-old male, he got transferred here to our emergency room from somewhere else, who knows. The EKG is diagnostic of, oh, it's not even a case. All right, 32-year-old male. So here we are. You guys can see my EKG, right? Case 246. We're going to go ahead and start applying our criteria. So I'm going to look at our precordials because that's where they see. So I'm just zooming in on V2, V3 right now. And so annotate. Okay, red line. So I'm just drawing a baseline here. And it looks like, yeah, there appears to be an ST elevation. So you can call a STEMI on this, maybe, but let's apply our other criteria. Is there concavity? So this looks kind of straight to me. It doesn't look like a smiley face. This one maybe right here, but it should be more pronounced of a smiley face like that for concavity. So I don't think it meets the concave test. Oh, that's annoying. Clear that. Here we have T waves that are actually inverted, so that doesn't meet that test either. Because remember, the T waves are supposed to be concordant with the ST elevation. There's a bit of a notch, so perhaps it could be benign early repole. So the last test we haven't looked at then is looking for reciprocal changes. So if I'm seeing elevations in my precordials, I should be looking at my limb leads. So zoom out. Oops. Can you guys see that?
Looks like it's really still just on, at least for me, on the main EKG, not like zooming in or anything, but you can see the limb leads and it looks like there is some ST depression, reciprocal changes.
Which lead?
It's like 3, 2, and 3.
AVF looks like it's down too.
I think there's a way I can get you guys to draw on this to show me. But the answer on this guy is supposed to be benign early repole. So if I'm zooming in, let's say on lead 2, the ST segment, I feel so slow with this, is right here. So we would expect a depression right there if we have true elevations in the precordials. So that would be no reciprocal changes. I can't zoom in and out easily. So I think I misspoke earlier. I might have led you astray. So the T wave here is concordant. So the T wave is pointing down and the primary QRS deflection is downward. So it's actually concordant. So I led you astray there. Does that make sense?
The stuff that you're drawing over my EKG isn't like corresponding to the EKG that I'm seeing. Like it's just in white space.
Right.
Oh, for real?
At least on this most recent part, yeah.
That's weird. It looks perfect to me. Am I moving it right now?
No, just like the EKG is
Not moving?
yeah.
Okay, good to know. I'll stop using the annotation thing. So what I meant by concordance was in V1, the T wave is downward deflecting and most of the QRS in V1 is downward deflecting. So that's actually concordant. I think earlier I said it was not concordant. So I wanted to correct myself there. And so the answer on this one is that it was actually benign early repole. So for our purposes, that's the answer. I'll get you a different example here.
What about the depressions in
especially in
2, 3, and AVF though?
I guess what like threw me off the most is like lead 3. It looks like the T waves are discordant from the QRS.
Well, the T wave in lead 3 is definitely flattened. It's almost biphasic. It's hard to tell, but it's definitely flattened. And the QRS is about as upward deflecting as downward deflecting. So it's about equal amounts upward reflecting and downward reflecting. So you would call that isoelectric. So I can't say that it's disconcordant, the T wave and the QRS. And then someone said there's ST depression in lead 2. Is that right? I'm not sure if we're looking at the same thing then, because there's like there's a swoop downward at the PR interval, and then there's a big QRS deflection upward, but then I'm not seeing a depression. I don't know if you guys are following me there.
Yeah, are you on
Picture
case
check.
276? That's the EKG that we're looking at.
Oh my gosh. No, I am not looking at that one.
Maybe you could quickly take a look at that, and then since we're running out of
Sorry.
time here, at least just look at that case 276, and then see if you kind of notice some of those things that we're talking about with those elevations in the V2, V3 with.
Okay, there, that's the one. I was like, what the heck are you guys talking about? Yeah, sorry. I have like 30 EKGs up and it didn't realize the numbers didn't match up. Sorry. That's a good learning point for us when we do EKGs in the future. So yes, there are, this case 276 is a STEMI. So good job. I tried to kill the patient, and you guys tried to save him. Just by now, it's too late.
We used our cuss words.
You guys are very respectful too. Oh my gosh. So I was literally looking at the wrong patient's EKG. So yes, ST elevations and concordant changes, and the T waves are discordant. So good job. That's embarrassing. I'm gonna pretend that never happened. Okay, so that one's actually a STEMI. How are we doing on time, Andrew? How long have we been going?
Depends on how long your headache one is.
It's 2:30. How long do I have until?
We got about 30 minutes.
Okay, so then I'll just do one other example. Let me find a good one then. Jeez, that was embarrassing. Okay, I got it. I'll just pull up the one from earlier that we all tried to do the quiz on, and then we'll apply our criteria. So 380. So now that we reviewed the criteria, we're looking back at the same EKG that you guys answered the quiz on. So looking at the precordials again, we have, now my annotations should be in the correct spot. So if you look at the baseline, clearly you do have an ST change. You have a inward scoop of the rise up. So now watch this. I'm gonna draw this happy face. See that? He's happy because this is benign early repole. What's our other one? You're gonna be looking for a notch. So if you look at the upper right around at the V6 area, the notch at the J point is another clear indicator right there. And that's called the fish hook. It's like a fish hook sort of thing. And the T waves are upright. And then I'm going to look at the limb leads to see if there's any reciprocal changes. And there are no depressions because we're all looking at the same EKG. The smiley face is following me. And if you look at the case as well, it was an 18-year-old male who came to the ER with chest pain, and it was a benign early repole.
So does that mean the chest pain is from really another cause? Or does this?
Well, this doesn't rule out ACS. It's just one additional skill set that you're going to apply. Just like a normal non-ST elevation doesn't, if you have a normal EKG, it doesn't rule out ACS in the same way this doesn't. But right. I've seen multiple times in emergency rooms and in clinic where you get these EKGs and there's like that minuscule little ST elevation in the precordials, and we're all like, oh shoot, what do we do with this? Is this real? Well, patient has chest pain. The history isn't that convincing. And so if you apply this criteria in addition to your clinical impression, it was being able to accurately just say, hey, this is actually benign early repole. We don't need to be worried about it. It's actually a very reassuring thing you can do for the patient. So
great. Thanks, Dr. Kim.
Okay.
Sorry not stopping you earlier. I thought it might just be my screen that was not lining up. So thanks, Molly, for saying something.
I was just very confused.
But that was helpful, Dr. Kim. So we can just go ahead and just jump right into your migraines one if you want to share that PowerPoint and get going, or whatever you made.
I actually didn't make a PowerPoint. I did a very, very deep dive and got lost and was like floundering, and my wife had to call to be like, come back to me, because what I actually did was looked at trying to see when it comes to migraines, everyone seems to have a decent grasp of it. And there's so many different areas like chronic, acute, different types of headaches, non-pharmacotherapy, pharmacotherapy, and alternative therapies. So what I wanted to focus on was the evidence on the pharmacotherapies on the outpatient side or the family practice side. So let me share, and I'm going to do this just basically via a whiteboard. Might clear all of this. I might have to adjust on the fly because I might have, like I said, I got lost. I did a nerdy deep dive, and I might run out of time. So that's all right. We'll be okay. But basically, it's going to be interactive. And there was actually a study a while ago that looked at a bunch of very experienced internal med and family med docs and had them guess or say what their impression is of NNTs of many things. The NNT, I'm sure you guys all know, is my favorite way to translate crazy evidence and medical jargon to a patient. So for every X amount of patients I treat, you get the benefit, and the benefit is specific to each thing. So each benefit should have their own NNT. What we're going to do, these are my objectives for you. We're going to look at and there were so many things out there, and given the time frame, we're only going to look at the acute migraine treatment, so not the chronic, and we're going to stay to the pharmacotherapy, not the lifestyle modifications and the alternative therapies. And then we're going to briefly look at the choosing wisely, which I think everything we're going to talk about is very applicable to the family med doc on the outpatient side. Thanks for being patient with me, everybody. Okay. So, like I said, this is going to be interactive. So I'm going to have the medicine on here. So we're going to talk about all the first line pharmacotherapy. So first line here, and then I'm going to have you guys guess the number needed to treat for that first line pharmacotherapy that you prescribe all the time in your clinics for these acute migraines, or maybe in the ER or wherever. And then I'm going to tell you the actual NNT. So we're going to have some fun. So somebody tell me a first line pharmacotherapy for acute migraine.
Naproxen.
Naproxen. So NSAIDs. Okay. And I will split that out for you. I like how he actually said a specific NSAID. And I'm going to assume someone's going to say ibuprofen. All right, what do you guys think the NNT is for naproxen and ibuprofen? How many patients do you need to treat to relieve their headache? This is going to be interesting. This might totally backfire on me, but whatever.
1 in 5
5 for which one? Both?
for naproxen.
Okay.
We got 30, 80 in the chat. I'm not sure if you can see the chat, Dr. Kim.
Well, no, I can't.
Yeah, so 5, 30, 80. My guess would be naproxen would be fewer NNT than ibuprofen.
Okay. And do you think everyone kind of thinks this is about the same for both? Okay. I'm going to keep you in a little bit of suspense just so we can list out the other first line. There's not that many, so I think we can do it. What other first line therapies do we have?
Earlier, I think Jared said triptan.
Okay, so triptans. I'll split it to the most common ones and the ones with the most data, and the only ones that I actually were able to look up the NNTs for. And so for those who care or don't know, that's Maxalt. What's sumatriptan's trade name?
Imitrex?
Good job. All right, what's the NNT? I'm sure there's activity in the chat. What is it
4.
for?
5.
Okay. What about max salt?
48. Thanks, John. We almost had consensus.
Isn't this interesting? Just because in your mind you think like something really works or doesn't work or whatever, so that it kind of reflects on your NNT. And then there should be one more first line that you guys should be talking about, which I haven't heard yet.
Oh, antiemetics? Is that what you're thinking of?
No, that's actually considered second line.
Caffeine.
Oh, caffeine.
Excedrin.
I heard someone mumble.
Caffeine was what someone said.
Oh, okay. That's actually, I'll talk about that a little bit later in a combo. So they have all these like this was crazy. This is why I got lost, because there's so many freaking combos and different ways to use different things. And then not only is it the pill itself a combo, the order in which you give something to a person is just insane.
Mahina said Excedrin migraine, which would be one of those combos. And then ergotamine is what Robbie said.
I guess triptan being an ergo derivative has been replaced. So the ergo, yeah, according to the AAN and the American Headache Society.
Oh, someone did say Tylenol earlier.
Yeah, Tylenol. There you go. What's the NNT for Tylenol for treating headaches?
10.
Okay, so you guys think it's, some people think it's a little better, some people think it's worse than NSAIDs.
Definitely worse. I feel like it's like 90.
Okay. Even like 90, 80, 30, it's not that bad in the grand scheme of things, right? When it comes to the medicines that we do.
I don't know, but I guess it's bad in the sense of like what I expect to happen when I give it to somebody.
Yeah, like it doesn't it always seem like, yeah, they failed this, and they failed that. So now I'm going to do Botox. So here's the actual NNTs. For IV, I'll do naproxen because that's the first one. And then I'm going to rapid fire a bunch of the original sources in the text box for you guys when I can pull it up. So for ibuprofen, the NNT to go from moderate to severe. Sorry, moderate / severe to get it mild in 2 hours. 3. Oh, excuse me, 7. Or ibuprofen for the relief, just like in before, and for 2 hours, so moderate to severe. 3. For complete headache relief at 2 hours. 7. So that right there kind of implies to me that maybe we as docs don't give naproxen and ibuprofen the credit it deserves, or maybe we don't try a little hard enough to appreciate, hey, is this the right dosing that you're getting? Have you tried it long enough? And maybe be a little satisfied, too easily satisfied with, okay, that doesn't work, we're going to move on to the next step. Because I was surprised by that too, like, oh, wow, it's actually 7. I know it's first line, but like the NNT is 3. There's very few things that are that low. So, and it's just ibuprofen. The first line therapy of triptan, let's go with the NNTs for that. So someone said for sumatriptan, it's 4 and 5. So complete headache relief at 2 hours for sumatriptan. Depends on the dose you take, but for the most part, it's 5. So good guess on whoever said it. For max salt, for complete relief at 2 hours, depending on the dose, it's 3 if you do it with the low dose, and it's 2 if you do the high dose. So that's pretty good too. And so again, that kind of raises a question for me, like how many times do we get patients who say, yeah, I already tried that, I already tried this triptan, it didn't work. Again, did it truly not work? Because all the evidence seems to suggest that it really, really, really should work. So are they taking it right? Are they just taking it throughout the day? You know, that sort of thing. How old is it? There's different formulations. And then lastly, for Tylenol, someone guessed 10 and 90. So the NNT for Tylenol at 2 hours to be pain-free, 12. So actually Tylenol wasn't too terrible, but here's the other kicker. At 1 hour, clinically pain relief. So it's not pain-free, but relieved clinically. That was defined multiple different ways. Oops, there's no round number, so it's 5. So Tylenol ain't that bad either. And so again, like this is all first line stuff, but I don't know, to me, it seems like almost every acute migraine person that we meet in our clinic, they always have failed all these things. And then we all kind of give the patient the benefit of the doubt, or the previous doctor that saw the patient. Yeah, okay, they already tried everything. I'm gonna move on to additional things. So this was just food for thought. I don't know, what do you guys think about what do you guys think about this? Is it surprising, not surprising?
I think it's surprising. I normally just give Tylenol and think like, okay, cool, placebo effect. So
yeah, whatever.
The number.
Yeah.
Surprising.
Is there anything in the chat box, Andrew?
Dr. Toma was mentioning how he just thinks that there's some effect of being prescribed a medicine and believing it's going to work better than an over-the-counter.
Yeah.
And then whether or not patients actually wait the 2 hours before saying it failed.
Right.
And like Amy just said, it may not even be a migraine. It's like patients are taking, maybe they have a tension headache and they just call it a migraine because it's a bad headache, or they're taking all of these medications all the time, and if they stop taking them, they get a quote unquote migraine because it's just a medication induced headache because they're constantly taking triptans and Tylenol and ibuprofen.
Yeah, good. So a lot of these NNTs were already calculated, but many of them I calculated myself by looking at the raw data. Close this box. Let me just send you. So in the chat box, I'm sending the Cochrane review, so the meta-analysis for Tylenol. I'm now sending the Cochrane review for the meta-analysis for ibuprofen. And now I'm sending the Cochrane review for sumatriptan. So if you want to double check my work or look and educate yourself a little bit more, you can feel free to do so, or you can ignore it all. Because that's not the purpose of this lecture, for you to become experts and do a deep dive into all these studies. All right, so that's all first line therapy. Now we're going to do the second line, and then we're going to end with some of those combo pills because they don't really fit anywhere. So let me clear this. Oh, whoops. I could just do that. All right, boom. Second line treatments. What do you guys got?
Compazine.
Compazine. What kind of, what's the class of drugs it's in?
Antiemetic, and then we've got Reglan along with that from Simpson.
Good. So antiemetics. So this is where it really goes crazy in terms of the combos you can do. So thanks, Dr. Simpson and Usman.
Yes. I mean, does just combo included on this second line, like just combining like a triptan and ibuprofen or whatever?
Yeah, I'll talk about that at the last, because the reason I'm separating it out is because this is how the American Headache Society wants you to look at it, and this is how the American Academy of Neurology evidence-based guidelines lays it out. And then at the end, they have certain things, and then don't do this, and oh, try these ones. So it's a little bit annoying, which is why I got kind of lost in the pool of evidence. So compazine, otherwise known as promethazine. Okay. And then someone said Reglan, right?
Yes.
Otherwise known as metoclopramide. And then, oh, sorry.
Propylpyrazine.
Sorry, I totally, this is not compazine. Oh, I can't delete it. Compazine is prochlorpyrazine.
Pyrazine.
Thank you. Hey, I guess now you guys know about promethazine as well, Phenergan. Okay.
What about steroids?
Yeah, so things like there's IV steroids, IV Depakote, and then IV actual ergotamine. Those I didn't think were very outpatient family doc worthy, so I didn't look into it too much. But those are for last line anyway.
Jared said ergotamine, and then John says ketamine.
Oh, I actually don't know about ketamine. I didn't read much about ketamine. I guess they'll take care of anything.
He's always giving that to his patients.
There's also Toradol.
So for some reason it was very annoying as well, and I didn't get time to look too deeply into it. But all the oh, actually, it is on there. Thank you. But a specific kind. Thanks, Dr. Dom. Okay. And someone said the ergo. I think that pretty much covers it. The last thing is magnesium. So this is kind of like in the clinic, you can start an IV or you can give IM medications to avoid an acute migraine, or someone comes to the ER with an acute migraine, then they don't need to be admitted, but you want to get their migraine better. So this is kind of that at that level. All right. So whoever said ergo can guess on the NNT.
That's Jarrett.
I don't know, maybe like 50.
50. Toradol?
Five is what Mina says.
Okay. So prochlorpyrazine, otherwise known as compazine.
15.
Yeah, I was going to say 15. Nice job. Teamwork.
And these are IV/IM. Okay, Reglan. Stephanie says 8. Oh, everyone's being more lower numbers than before now. Well, it makes sense, right? We're getting more like IV, IM. That makes sense. Okay, promethazine, otherwise known as Phenergan.
10.
Pretty good. And then for MAG.
40.
Yeah.
Yeah, it's like one of those supplements that you can give to people. That makes them feel better.
Pregnant people.
So the intranasal ketorolac, which I've actually never prescribed. I don't know if it's even orderable, but it was in the guideline as one of the first second line agents to use. And it's in the.
You're talking about ketorolac or the ergo?
Oh, sorry. Both. Well, I've used intranasal. Sorry, that's a. I should clarify. So there's intranasal triptans, specifically sumatriptan. So that earlier article that I sent you actually looks at this, the triptan Cochrane review. And then they just have the pure dihydroergotamine. It just has a lot of side effects. So for the sumatriptan intranasal, at 2 hours for complete pain relief is 4. For the dihydro, at 2 hours for partial is 3, and complete is 11. And then the data for the sumatriptan is the most robust. And so if someone is not able to take, what this says to me is if they failed PO triptan, my next go-to is going to be an intranasal triptan because it's pretty darn good when it comes to the actual NNT. And that's supported by the meta-analysis that I sent you. The one that I haven't done is the intranasal toradol. Has anyone done that?
Nope. Yeah, just
Whoever guessed 5 is spot on. So 2 hours is actually 5, but it was never for any primary outcome. So things like sustained headache relief, it was like a partial relief, and then everything kind of came back, and there's a bunch of other secondary items which are too esoteric for us. So I think of it as an option, and it's 5, so it's still a decent option if you're trying to get some of those secondary outcomes. Let's talk about the antiemetics. So prochlorperazine, compazine was one of the first ones that someone
Dr.
said.
Kim, I
Yeah.
have a question.
Yeah.
So it didn't talk about like IM Toradol at all, because I feel like we do give that quite a bit for migraines, especially in the ED.
Yeah.
They do that all the time.
So the evidence in all of the guidelines didn't specifically mention IM Toradol, but it did mention NSAIDs used in combo with other ones. So it kind of makes sense that you might just say it's the same category as the ibuprofen and naproxen, because there's studies out there that kind of say those are pretty equivalent, probably getting a lot of placebo effect by giving a shot instead of just giving them a pill. That's a good question. All right, so for compazine, it's actually pretty good. So most pain relief. So I forgot exactly how they defined that, but it was a very significant pain relief. So not complete at 2 hours. It was 3. So compazine seems to be one of the best ones to use in the ER, especially if you already have IV access, although you can just do IM. So in clinic, you can do it as well if you have that. Reglan was anecdotally has been one of my favorites. And their NNT that they report is a little bit unique. It's not 2 hours like many other studies. It's needing rescue medication at 30 minutes. NNT equals 4. Needing rescue, 30 minutes. So I guess if I was an ER doctor, I don't necessarily care about the 2-hour relief because I'm trying to get people out of the ER. But if I can get them feeling better within 30 minutes with Reglan, I like that better because then I could dispo them, right? So interesting way and an interesting take on the NNT. And then promethazine. So this one was actually really frustrating because Phenergan is also historically, personally, just one of my favorites because you can give it as a PO and as an IM. Unfortunately, it was extremely hard to find the actual original studies. And I think it's because there aren't that many. So I had to do a deep dive and find one. So I couldn't find one for IV or IM, but for PO, this is complete headache freedom at the 2-hour mark, 8. And this was actually a relatively recent study. Randomized control trial, promethazine compared to a placebo. I thought that was pretty cool. Again, it is PO, not IVIM, so I don't know if it's going to be better or worse. It was really frustrating that I couldn't find it. And then for magnesium, They also did it just like the Reglan for needing rescue at 30 minutes equals 5. So again, even though we kind of talked and we were gonna, and it seemed like everyone was guessing a little bit lower on the NNT, it's still pretty darn good when they said the actual NNT, right? In fact, it's actually almost as good as all the first line medications. So they explained that it's becoming second line because this is when you start entering into how easy it is to take it, what are the side effects, what are the risks of addiction, that kind of stuff. Did they discuss the dose of MAG? I believe they did off the top of my head. I don't remember. It was IV magnesium, dose of MAG, but I'm going to be giving you guys all the same exact articles I use. So Mina, awesome. I love you, Mina. American Headache Society, level B evidence. That's what I'm giving you right now. The American Headache Society evidence assessment of all the treatments. Here is the Reglan studies that I use to calculate the NNT. Here is here's Compazine, a huge meta-analysis. I looked at Compazine. And then here is the last one, the Phenergan, and Compazine compared with, and then another one with just Phenergan by itself. So we're coming up on 30 minutes. I do want to just leave you guys with one last thing. And this was more like a, hey guys, just, I want to see what the perceptions are of the NNTs, of how effective our treatments are. Looks like we all kind of got that message out of this, right? Like, oh, perhaps these are all a lot more effective than we give them credit for. And then if you care or you're interested, you can look at all the primary sources that I'm bombing the chat box with. But this last one is really cool. I'm not going to waste any time and just give you the articles. Well, here's one on Excedrin. So aspirin, Tylenol, and caffeine.
Didn't they just pull Excedrin from the shelves?
Did they? I don't know. Can you tell me about that?
That's all I know about it. I was trying to Google it the other day, and the only thing came up was like news articles, and I didn't click any of them, I'll be honest. It better not freaking pull Excedrin from the shelf.
So the other thing, the other flip side, that's the other half of this that we're not looking at, is the number needed to harm, right, for the side effects, and then also the cost, and then how easy it is to give that medicine. So that's kind of why these ended up in the first line, second line, and then there's like basically the do not do unless it's the absolute last thing, like opioids and butalbital, which is Fioricet. And that's actually the choosing wisely stuff, which we're not going to go into because for time's sake. But the last articles that I sent, I wanted to give to you was the one that starts with a 9 and the one that starts with a 10, because it made it into the American Headache Society and it made it into the American Academy of Neurology as far as one of the combo ones to use that actually works. So the Excedrin actually does work as shown by the RCT that I shared with you in the trial. The main downside though is the risk of the medication-induced chronic migraines. The other one that was a combo pill was looking at specifically naproxen and sumatriptan together. I can just show you. Excedrin is in shortage, not recall. Thanks for the clarification. I guess everyone's getting headaches staying at home. And then I'll just clear this up. I'm just gonna write it out. So for triptan plus naproxen, then the This is Excedrin, so acetaminophen, aspirin, caffeine. When you compare it to placebo, the NNT to be completely headache-free is 3. So again, pretty darn good. But then when you compare it to just triptan by itself, it's 10. So again, not bad. So in my mind, I have to treat, if I'm treating somebody with triptan already, if I add on naproxen, I only need to do that 10 times and I'll achieve complete headache freedom at 2 hours. But here's the best thing. Sustained 24-hour headache response. NNT, if you add naproxen to triptan, is 5. So I'll get them not only headache-free at 2 hours, but also sustained 24-hour relief. So avoiding the chronic bounce-back migraine headaches. And that was kind of the big thing that I saw was really cool, is this sustained response and the fact that it's already really good against placebo, and you only need to add 10 more to people you give with triptans already. The number needed to treat using that RCT that I sent you for the Excedrin is 1 for Excedrin. So I guess Excedrin is pretty awesome too. It was like 1.34 something. But the main way that they did it was something that no other study did. They looked at headache PAR scores, which are like summative pain scores. So I'm not sure, we haven't done a journal club on it. So does that mean something clinically significant? I'm not sure. But using the PAR scores, which is a summary of their overall pain scores, the number needed to treat was 1 for 2 hours of pain relief, or 2 hours pain relief. Pain relief at 2 hours, number needed to treat was 1.
Thanks, Dr. Kim. That was really helpful, I think, to see the numbers like that. And it's actually a good segue into the next lecture, which is from our Botox providers, the company that does Botox for migraines. And so they're probably going to talk to us about their version of chronic migraine treatment. And I think we often send people for these chronic migraine treatments, maybe without them adequately failing some of these treatments. And I wonder, at least some of my patients, if they actually have given some of these, different medications a real try before, saying that they're kind of failing them. So in order to get to the next lecture,